Very good morning and good afternoon, everyone. I'm Professor Budi Wiweko as a chairperson of Aspire Webinar Series 2020. We proudly present the Aspire Webinar Series, particularly the Part 2 add-on in the ART Lab with our three distinguished guest speakers this morning. They are Professor Atsushi Tanaka from Japan, Associate Professor Deirdre Zander-Fox from Australia, and Dr. Haroon Latif from Lahore, Pakistan. Our webinar series this morning will talk a lot about how we can enhance our competencies, our quality services in embryology laboratory in order to get the good quality of embryos, of course, for increasing the pregnancy rates in our daily practice. Before we go to the live session for discussion, which is I'm sure all of you is already watching the pre-recorded videos lecture from our speakers. So I will introduce you the first speaker, Professor Atsushi Tanaka from Fukuoka, Japan. Right now, he's the director of Saint Mother Hospital, located in Kita, Kyushu City, Japan, and also the visiting professor of Juntendo University of Obstetrics and Gynecology in Tokyo. He obtained his postgraduate degree from Department of Obstetrics and Gynecology, Juntendo University, and also reported the first successful gift in Japan in 1985. He reported the first successful microfertilization in Japan, 1992, and also his manuscript about ROSI, round spermatid injection, were published in 2018 in Fertility, Sterility. I think he has long-standing interest in the scientific aspect of reproductive medicine, biology, and spermatogenesis. Good morning, Professor Atsushi Tanaka. And then our second speaker is Associate Professor Deirdre Zander-Fox from Melbourne, Australia. She is Scientific Director of Victoria Monash IVF and KL Fertility. And also she is Associate Professor Monash University and University of South Australia and University of Adelaide. She completed her PhD studies in 2010 through the University of Adelaide, and she's currently the Monash IVF Group Regional Scientific Director and oversees Monash IVF Victoria in Malaysia. She is responsible for embryology, genetics, andrology, and endocrine services. Deirdre supervised numerous PhD and honors students and held as a young associate professor position at 3 universities. So very good afternoon, Deirdre. And the last, our speaker today is Dr. Haroon Latif from Lahore, Pakistan. Haroon, he graduated from Bagai Medical University, Karachi, Pakistan in 2001 with Bachelor of Medicine and Bachelor of Surgery. He obtained Master in Clinical Embryology from Monash University, Melbourne, Australia in 2005. He joined Lahore Institute of Fertility and Endocrinology, leading RT clinic of the country as a clinical embryologist in 2006. In the short period, he became lab director and chief executive of the clinic. And also he obtained fellowship in sexual medicine, European Committee of Sexual Medicine from Holland in 2012. So besides working in assisted reproductive technology, he runs a successful sexual medicine clinic with a group of urologists and psychologists. And right now, is a General Secretary for IVF Society of Pakistan. Good morning, Haroon. So before we go to Q&A sessions, I will allow you for each speaker, starting from Deirdre, to state maybe some keywords. What is the important things about your topics? Maybe 2 or 3 minutes. Please, Deirdre.
Thank you very much, and good morning or good afternoon to everyone, and thank you to Aspire for having me come along and be able to talk to you today about Piezoexe. Probably the most important things and most exciting things that I want to highlight about Piezoexe is that I do think that this is a more gentle and delicate form of microinjection, and I do think that this technology is a very important technology compared to our current microinjection techniques, because I believe it is less damaging to the egg. And I do feel from the studies that have been published and also our initial work in Piezoexe that it does result in improved fertilization and increased embryo number for our patients, which is going to hopefully be very important for cumulative pregnancy rates per cycle as well.
Thank you, Deirdre. So less damaging ICSI to the outside. Thank you. The next, I will allow the Professor Atsushi Tanaka to say some important keyword about your topic within 2 or 3 minutes.
Thank you very much for inviting me this Aspire webinar. It's my great honor. As you know, also observation is the most fundamental event before the birth delivery. So it says that activation is the mother of our life. So even still now, many things remains unknown, the mechanism of fertilization. So today I would like to talk about oocyte activation is when and how to do use for the unfertilized eggs. It's not completely answered, but I think it's very important. So I hope my answer might be a good chance for you to help your clinical application. Thank you.
Thank you, Susie. It's very interesting message. Yeah, oocyte activation is the mother of life. Very important. And the last, Haroon, please. What is your keyword of your topic?
Thank you, Budi, and thank you, Aspire and Aspire Education Committee for this opportunity. My topic is assisted hatching. What's the evidence in 2020 now? Obviously, I think if you talk about add-ons in ART or IVF, assisted hatching is probably one of the oldest add-on which is being used. It's been almost 30 years now, almost 3 decades since it was introduced. But for various reasons, it hasn't really caught up with the ART professionals, and there are a lot of concerns around it as well. So in my presentation, I reviewed the Cochrane review that came out back in 2012, 2013, and what's the evidence after that. We've seen that there are limited publications as far as assisted hatching is concerned, and it has been toyed for patients who are poor responders or who have a poor ART outcome, but with limited success. It has definitely shown increased clinical pregnancy rates in some of the cases, increased implantation rates also in some of the cases. However, when we come to live birth rate, which is the most important part, taking a healthy baby home, it hasn't shown really promising results till now. So I've reviewed the Cochrane review as well as discussed the publications which has come out after that. And basically, I hope I've managed to cross my message to the people, because there's more, the evidence is still not enough to decide whether we should be adopting it for all patients or not.
Okay. Yeah, thank you very much. It's still sufficient evidence here to adopt as thing for all of our patients. Thank you. So before we go to the questions that are coming from the participant already, I will also inform all of the audience. Right now we have 55 attendees. So I will let you know please, if the participant want to asking some question, please typing in the Q&A box. Q&A, please go to the Q&A box, and then you can type and then chat and express your question directly through the Q&A box. Okay, we start from the question that's coming from the audience before. This is the number one. Maybe you can answer the three above the top three questions. This is, what is the best method for doing assisted hatching? And then, is assisted hatching for everyone? And then the last, what are the long-term consequences of assisted hatching? Please, Haroon.
Yes, thank you, Budi. So the first question is, what is the best method of doing assisted hatching? When assisted hatching was introduced, as I mentioned, about 3 decades ago, 28 years ago, it started off with mechanical assisted hatching, which is partial zonar dissection. And there have been different methods within partial zonar dissection which have been introduced as well. There is small partial zonar dissection, there's long partial zonar dissection, depending on what kind of dissecting needle are we using. The concern that revolves around partial zonar dissection is the mechanical injury, the potential mechanical injury we can do to the embryo, because a lot of manipulation is required when it comes to physically thinning out the zona using a very fine, sharp needle, holding the embryo with the holding needle, and then using the sharp, fine, thin needle to dissect the outer part of the zona or even a larger part in it. Then after some time, the second method that was introduced was using acidified thyroid method. Acidified thyroid method became very popular because by using this acidified thyroid, or also in certain cases, there's an enzyme called proteinase, which can also be used to basically initially to thin out the outer layer of the zona pellucida that would potentially assist in helping the embryo to hatch, as we do in assisted hatching. And also acidified thyroid can be used to even make get rid of the zona completely. There have been studies on it in which they've used it to remove the whole of zona and seen the results, the impact on implantation and pregnancy rates, and also to make small a hole in it instead of just thinning it out, actually breaching the zona itself. Acidified thyroid was also used for a number of years, but the concern with acidified thyroid method is that you need a certain level of skill set in doing that, because you fill the acid thyroid in a pipette, you hold the embryo with the holding needle, and then holding pipette, and then you basically pour acidified thyroid on the zona. So you need to be very skillful to put the exact amount of fluid on the zona pellucida, because any excessive fluid can potentially harm the embryo and can harm it to the extent that it may not be transferable later on. So a certain level of skill set definitely required with this method of doing assisted hatching. Then after that, obviously, the laser came out, and the laser is being used widely, as we all know, for our embryo biopsies in PGT cases and PGS cases. So laser-assisted hatching has become very popular. Mostly the clinics who are still doing assisted hatching are basically using laser-assisted hatching. It is a much easier method to do as compared to when you talk about mechanically dissecting zona pellucida or by using acidified thyroid. The laser, as we all know, is very precise. You have an option to just thin out the zona pellucida, or you can actually breach it. And when you breach it, you have an option on the size of the hole. It can be as low as less than 5 microns to as big as up to 30 microns. And there have been studies on it which have reviewed these different methods and their results and the outcome. The concern with the data which is available is that a lot of these studies have compared mechanical zona dissection with the acidified thyroid. but there haven't been many studies which have used all the three methods together and seen which is actually the best method to use. So although, because I think the laser has been taken up, so that's why the limited data as far as when you plan to compare all three. So these are the three basic methods which are being used, but mostly now laser-assisted hatching is the most popular one.
Okay. Okay. Thank you, Haroon. Maybe we stop until now. So I'm going to the second speaker, Tanaka, Professor Tanaka. This is the first question. How can we predict that we need to do oocyte activation? In which case, actually?
Yes, I think it's very, very hard questions because, as you know, about 20 to 30% of oocytes after ICSI are not fertilized. But usually when we feel necessity of this oocyte activation is very limited case, I think. So my idea of indication is when the patient is less than 40 years old, I exclude advanced age people. Less than 50 or less than 50%, half of the oocytes are unfertilized. And on condition that the previous cycle had more fertilization. And second, I think the most important thing is oocyte quality is high. If oocyte quality is low, oocyte activation is ineffective. So my answer is if the patient is lower, 40 years old, and repeated the 50%, less than or more than 50% on fertilization, and oocyte activation, oocyte quality is not so bad. In these cases, I think oocyte activation is necessary.
Okay, so there's one question from the audience. Normally, patients with first attempt should use oocyte activation or not?
No.
Okay. No, okay. Very clear. So no, okay, okay. The first time is no need. Okay. Thank you.
Of course, after observation in detail about oocyte one by one, and if the oocyte has a good quality, no, we don't do the oocyte activation from the first trial.
Okay, thank you, Susie. So the next we go to Deirdre. Yeah, this is the first questions. Do you think that Piezoexe can avoid zona pellucida injury and should be performed in every cases?
Thank you. That's an excellent question. I think that Piezoexe is an incredibly elegant form of microinjection, and the way that it is able to micro drill through the zona is, I believe, significantly less damaging than standard ICSI. Whether or not it should be performed in every case, I do think that there are potentially some patients that don't do as well with Piezoexe, although it may be less damaging to the zona pellucida. I do find from my experience, and I haven't been using this technology for a very long time, but there have been some patients where we are currently performing a sibling split trial where they've done better with standard ICSI fertilization than piezo. And I do wonder if there are some patients where that cytoplasmic agitation is better at activating the oocyte than Piezoexe. But certainly from a zona pellucida damage perspective, I do think that Piezoexe is a more gentle technique and will be less damaging to zona pellucida injury.
Yes. In your lecture, you mentioned also about the use of mercury. for doing Piezoexe? Is it safe so far?
So historically, Piezoexe, mercury was used inside the micro injection pipette to give the pipette inertial mass. So obviously that was used historically, but there are now more safer operating fluids that can be used. I certainly myself wouldn't feel comfortable having mercury in an embryology laboratory. So obviously a lot of clinics are using a different type of operating fluid now called Fluorinert. And in some of the studies that I've been doing, we've been using another type of operating fluid, which is used in eye surgery, which is a completely inert, dense fluid per fluorooctane, which I think is much more biomedically compatible.
Okay. Yeah, this I will continue the question from Claire in the Q&A box. So do you have any data from RCT trial comparing Piezoexe versus standard ICSI on embryo aneuploidy?
No. So currently, I'm currently undertaking two trials. The first one is about to hopefully be published, and the second one is ongoing. But I haven't extended that to look at euploidy or aneuploidy rates. A lot of the patients enrolled in the trials have been undertaking PGT. So certainly I do have that data available to look into, but it's not part of either of our trials currently.
And then which company for the make Piezoexe equipment? What is Fluorinet?
So I'm using PrimeTech piezo technology, which is being now in Australia, is certainly being sold through Vitrolife, and Vitrolife have the operation fluid available.
Okay. So the next we go to the Sushi, Tanaka. This is the question regarding oocyte activation. Should we do cytoplasmic agitation routinely in all ICSI? Should we do cytoplasmic agitation routinely in all ICSI?
Yes. I think the first report by Tesalik. So Tesalik reported the Rossi successful case. In such case, he told me that the oocyte activation was done with vigorous aspiration and the pipetting of oocyte plasma is enough. But I show that it's not effective. So my answer is agitation is not trigger the oocyte activation. It's not effective.
Okay, thank you. Thank you, Susi. So now we go to Haroon. So Haroon, can you answer the question, what are the long-term consequences of assisted hatchings?
So yes, it is very important, and basically this is the crux of whether we should be doing laser-assisted hatching or not, or generally assisted hatching or not. As I mentioned previously, that although the data which is available have limited information, or I would say almost no information on what are the long-term effects of doing assisted hatching. Especially the concern is around using laser-assisted hatching, which is now widely being done, whoever is doing it, because as we all know, there's a debate going on of doing non-invasive embryo testing as far as PGT is also concerned, right? The only reason is that we don't want to expose the embryo to that high temperature, to thermal injury, as we don't know what epigenetic changes may be formed later on going forward. So definitely we don't have the answer to that whether doing laser-assisted hatching, using any of the methods, and especially laser-assisted hatching, what are the long-term effects on epigenetics on it. There've been a study which they studied mouse embryos, and they saw there's a decrease in mRNA in embryos when they were exposed to this thermal injury. So we really need to look into it and be very careful when we when we do laser-assisted hatching because we don't know the long-term consequences. Another mid-term consequences that they've seen an increase in monozygotic twinning when we do assisted hatching. So in the literature, a couple of studies showed that monozygotic twinning rate is higher in embryos who have undergone laser-assisted hatching, although that hatching was done generally on day 3 cleavage stage embryos, not on day 5, day 6 plus assisted embryos.
Yeah. I think it is also the related question with the safe of assisted hatchings. Do you think it favors to doing assisted hatching earlier in embryo development, given the size of perivitellin space, compared to later on, despite the zona being thinner at the later stage? What is your comment?
So the data which is available and the Cochrane review that came out in 2012, 2013 also reviewed the literature. And in the literature, most of the assisted hatching procedures were done on day 3 cleavage stage embryos and not on day 5 blastocyst stage embryos. According to that data, the implantation rate and the pregnancy rate was slightly higher in some of the studies. However, it did not have any positive impact on the live birth rate. So maybe the embryos were surviving better. Maybe one study also saw that the implantation rate is slightly earlier as compared to non-hatched embryos. That assisted hatching might be helping the embryos to get contact with the endometrium slightly earlier. However, a higher pregnancy rate and high implantation rate is important, not that important if you don't see the result in live birth rate. So, honestly speaking, there's not enough data on blastocyst stage embryos to compare it with the cleavage stage embryos. Although, if you talk about PGT, we know that we prefer doing biopsies on day 5, day 6, rather than doing on cleavage stage embryo, because survivability on day 5, day 6 is much better as compared to day 3.
Okay. Thank you, Haroon. So for Deirdre, there's a question from the Anli. This is in Q&A box. Compared to conventional ICSI, is Piezoexe faster?
No, Piezoexe is not a faster technique. I feel on average it probably adds 50% time on top of a standard ICSI technique. There is certainly a learning curve to this technology as well, and as people get more proficient at it, they certainly speed up, but it is certainly not a faster technology.
Okay, thank you. This is also, there is a question for Professor Tanaka regarding the oocyte activations. What level of poor fertilization in previous cycles do you think that we should doing trigger to using oocyte activation in subsequent cycle?
I'm sorry, I can't
okay.
understand.
What level of poor fertilization in previous cycles that we think that we should doing oocyte activation?
I got it. So as I told you previously, so oocyte activation should be done. So considering many points, not only one activation rate. So if in terms of activation rate, maybe 30-20%, on condition that the previous cycle has higher success rate or continuously very low success rate. Both of two types are candidate for the oocyte activation. However, actually, success rate is, I think, is very low. However, different methods you may try. So because the basic important thing is oocyte quality. So at first, my idea is to increase the oocyte activation. Fertilization increase is to increase the oocyte quality. This is the first step. And if the oocyte quality is good, and suddenly it drop, and with the same embryologist, same technique with Piezoexe, so next step is oocyte activation is necessary. In such a case, I think Piezoexe is promising, but it's very difficult to get it. So now we are using the IP3. IP3 it's available from Sigma. So IP3 adding small amount in the medium, I think now I found it is very high, good result. So I recommend using IP3. And if possible, Piezoexe is, you will be satisfied with the result.
Okay, so do you have any specific cutoff point for poor fertilization rate in the previous cycle? Let's say 40% or 30% that we should doing oocyte activation?
Roughly speaking, 20 or 30%.
20 or 30%. Okay. Okay, thank you. Thank you. Okay, the next question is from Dr. Anli as well. See, what is the true indication for assisted hatching, Dr. Haroon? What is the true indication?
So yes, obviously assisted hatching when it was introduced and even later on, it was encouraged for patients with who are either poor responders, advanced maternal age, who had previous IVF failures. So these this is the set of group assisted hatching was encouraged to perform with. A lot of studies which have reviewed the potential group of patients who need assisted hatching have seen, again, coming back to the same point, that patients who've had previous IVF failures or patients in advanced maternal age, they've seen a slight increase as far as the implantation rate and the clinical pregnancy rate is concerned. But when you compare the results for the live birth rate, then the results are both comparable in assisted hatching group and in non-assisted hatching group. So it has been encouraged to use assisted hatching in some of these patients, but it does not have any impact on the live birth rate. So basically, it could be beneficial for implantation, but not live birth rates, and it may be beneficial in poor prognosis patients as well.
Okay, thank you. Thank you, Haroon. So for Deirdre, so what is the advantages and disadvantages of Piezoexe?
So I think the advantages to Piezoexe is, like I've said, it's a more gentle form of microinjection. So there is, I think, less stress, mechanical stress placed on the oocyte. There is no cytoplasmic aspiration. So the literature and even what I have experienced is lower rates of degeneration, higher rates of fertilization, which increases obviously overall embryo yield for a patient per cycle, and potentially more embryos available for transfer or freezing. Obviously, there's still a lot that needs to be done on this in regards to live birth rates, cumulative pregnancy rates per cycle. And I think that question before about aneuploidy is really interesting as well, and looking at are there any other benefits that we haven't seen. The disadvantages to this technology is that it is a slower technology and it does take a bit more time. The loading of the operating fluid is quite fiddly, and there is certainly a learning curve to this technology as you become proficient in it. And I also do think that potentially there are the odd patient that may not really benefit from piezo, that may need the more traditional form of ICSI to help with oocyte activation. So I think there are some things that do need to be considered, but on the balance, I think that the pros outweigh some of the challenges.
Okay, thank you, Deirdre. So the next question is for Sushi.
Yes.
How about oocyte activation due to bad quality of sperm? Is it help to increase fertilization rate?
I don't think so. I'm sorry. Because
Yes, any benefit for doing oocyte activation in bad quality of sperm? It will
yes.
increasing the fertilization rate or not?
Okay, I can hear you very, very well. So, except the global spermia, it's a very special sperm without acrosome. In such a case, acrosome deletion case, so oocyte activation is mandatory, indispensable. But usual, if the sperm head shape is normal and the vacuola is not so deep, shallow, it's okay. In such case, even if the motility is very slow, I think it's the same fertilization rate. So I don't think the sperms doesn't affect so much about the oocyte activation. So if the sperm is, even if it's very slow, it's slow moving. So no different outcome with compared with a very good fast moved sperm. The most important thing is oocyte quality.
So in globosospermia, any benefits?
Yes, that's true. It's necessary. Globosospermia, in such a case, we need oocyte activation. So in such a case, usually until now, the culture I know for is maybe popular. But I think I recommend IP3 adding in the medium, or if you could, PS Vita, I think it will get the more higher success rate.
In globosospermia, is
Yes.
according to your experience.
Yes.
Okay. Yes, the next question for Haroon, before we go to the case illustration, this is coming from Professor Ali Budiono. What is the normal hatching mechanism so that we can decide and choose the most appropriate hatching technology? And how do you think about zona hardening mechanism?
Yeah, so as I mentioned earlier, different methods of hatching are being used, starting from the mechanical dissection to the chemical method and to the laser method. So what we need to know is that, especially when the embryo needs to hatch at day 5 or day 6, and a lot of energy is required for the embryo to hatch. The inner cavity of the embryo has to contract and then expand, and it has to do it a number of times so that the outer layer, the zona pellucida, is broken down, and the embryo, the inner cell mass can actually come out and make a contact with the endometrium. So a lot of energy is required to do that. We have also seen that in blastocysts, in low viable blastocysts, this hatching process is hindered. Hence, it was also assisted hatching is stored for especially those blastocysts which are not of A grade quality and which have a low viability, so that they are assistant, they don't have enough energy to actually contract and expand in such a way that the outer layer is broken and they can come out of the cavity. That's why this is the mechanism. I feel obviously both the acid thyroid method and the laser-assisted hatching method, both of them have shown promising results. With good skills, you can use laser acid thyroid method as well, and obviously laser is very easy to manipulate and use, as we all know that. However, coming to the long-term consequences, as I mentioned earlier, there are concerns around the laser method.
Can you slide show? Yes. Okay. Yes, this is for the illustrations. The case number 1, the female, 30 years old, with history of 3 previous IVF failure, with 2 times cancellation of ET due to unfertilized of all sides and very poor cleavage rate. She has history of endometriosis before, AMH 2.5, and sperm analysis with normal with good DNA fragmentation index. she plans to perform the fourth IVF cycles. So what is your suggestion regarding your its topics? Do we need to perform Piezoexe, or do we need to perform a planning oocyte activation, or do we need to perform assisted hatching in this case? Deirdre, please, what is your comment?
So obviously, I'm a bit hesitant to use Piezoexe in patients where they have had very poor fertilization before. My limited experience of this is that it might not assist. If anything, it might be too gentle for them. So seeing this form of, with very, very poor fertilization and poor cleavage rates, but with very good sperm, I would normally look to some form of oocyte activation. So I would normally start with more of a cytoplasmic agitation. So more, we call it double injection, or that more, multiple, take the sperm, put it in, take it out, put it in again. So that cytoplasmic agitation. And then if that didn't work, I would potentially then consider stronger, such as ionomycin.
Okay, thank you. Shushi, what is your comment or suggestion?
Okay. My answer is she is younger, but she had operation of endometriosis. So AMH is just a little lower for her age. So I think the ovarian function reserve is decreasing. So most important thing is how to choose the ovarian control stimulation method. So I think I recommend the general antagonist-based method with, if the first, within 3 days of starting a period, if LH level is less than 5, I use to recommend HMG, not FSH. And with 300 international units per milliliter for every day to induce the number of follicles and check the hormone level. And if it's a total level over 2,000, we wait it reach 2,000 or at least one.
Okay.
And then I follow the Piezoexe definitely.
Piezoexe.
No, Piezo.
Okay.
Piezoexe.
Okay. Do you plan to do oocyte activation in this case like this?
No, we don't.
No.
No.
Okay. Okay. Thank you, Susie. Haroon, please. Do you planning to perform laser-assisted hatching? Yeah.
So in this case, I think one helpful information would be that how many oocytes were retrieved at the time of oocyte pickup. This does not say in the case study. That would be helpful. Echoing Sushi's concern that we need to revisit the stimulation protocol to see if we can get a good number of oocytes when retrieved. Definitely, I think laser-assisted hatching would not be assisting in fertilization of the oocytes to start with. So not for this patient, until and unless on day 5, when we're going to do the transfer, we see what the condition of the zona pellucida is. If the zona is very thick, then maybe thinning of the zona pellucida with laser-assisted hatching might be helpful in this case. However, I think oocyte activation, in my opinion, would be a way forward for this particular patient.
Okay, thank you. There is some question from some comment from Dr. Ivansini regarding this case. So anyone has any thoughts of endometriosis is affecting cytoplasmic competence, then oocyte activation may play a good role. So any comment for this? Susie? What do you think?
So I would like to know the previous history. So how many eggs could she retrieve and quality of egg? If I think maybe judging from the AMH level and the past history of surgery, so total number is less than 10. So in such a case, I think to get a high quality, so we choose antagonist base and COS, and with the Piezoexe is very, I think is very effective, and also laser assist hatching is also I will do it.
Okay. Okay, thank you. There is another comment also from Professor Arif Budiono. Yeah. Besides reducing the damage to the zona pellucida and cell membrane damage, will the use of Piezoexe also damage the membrane nucleus? Is the needle you are using in Piezoexe is normal ICSI needle or non-beveled needle? Yeah, please, Deirdre.
So the needle used for Piezoexe is not a beveled needle. It's a flat tipped, very fine needle. So it looks a little bit more like a trophectoderm biopsy needle, but obviously is a thinner diameter. And no, I'm not concerned about the damage to did you say the nucleus or the metaphase plate, or not concerned about that. It's a flat-ended.
Any damage with to the nucleus? Piezoexe will have any damage effect to the nucleus?
It shouldn't do. I mean, everything is very similar to standard ICSI in the sort of more in the diameter. It's a very fine pipette going into the same, you have the polar body at the same position, going into the same region of the egg, but there is no requirement for cytoplasmic aspiration. So the damage should be less, if anything.
Okay, thank you. The next question for oocyte activation. Is there any updated research elucidated the effect of oocyte activation on gene expressions to assess the safety of the treatments? Any study about the effect of oocyte activation on gene expression? Susie?
Yes, there are many papers about that, but I think it's a stage of study level, not clinical level. But it's now illustrated that some gene expression plays a very important role for the fertilization. So we have to study from this point of view further study, next step.
Okay, thank you. So we need doing further studies. Again, there's one question regarding the assisted hatching about the best time. When is the best time to do assisted hatching for Haroon?
Yeah. So I think as we discussed just a little bit earlier as well, that the data which is available, a lot of studies that had come out and that was reviewed in Cochrane Review in 2013 was looking at assisted hatching only on day 3 embryos. Very few studies were there who had looked at day 5. And now after that, recently in a systematic review, they have reviewed the data which has seen assisted hatching on day 5, day 6 embryos. Obviously, it depends on the method of assisted hatching are you using. Are you breaching the zona pellucida, or you're just thinning the outer layer of the zona pellucida? In my opinion, I think a better time to do assisted hatching would be at blastocyst stage. At blastocyst stage, you look at the embryo. If it seems like a low viable embryo, then obviously there is literature which says that low viable embryos will have a difficult time to hatch. As I mentioned, it needs a lot of energy to come out of that, to break that zona pellucida. So at day 5, day 6, using either laser or acid thyroid and thinning the zona pellucida would be a good time to perform this method of assisted hatching.
Okay. Yeah. Thank you, Haroon. So the next is the question for Piezoexe. Deirdre, do you think any difference among embryologists when doing the Piezoexe?
Yeah, another excellent question. Yes, I do think that there will potentially be some differences in this technology between embryologists. So I do think potentially once they become very proficient at it, potentially the variance should be less than what we see with ICSI. Certainly we see with ICSI often quite large variance between scientists with their fertilisation and their degeneration rates post-ICSI. I think that will be less with piezo, but definitely there is a finesse in loading the pipette, getting the settings right on the piezo to make sure the pulsing is right. If you use that too high or too that it's too fast, or you have the settings are too high, you can induce damage. So that would need to be assessed quite carefully. And also, I think if you're using the piezo technique to immobilize the sperm as well, there's quite an art to doing that instead of the traditional striking. And that also requires, I think, careful education and training on that as well, to make sure you do adequately pulse the sperm and disrupt the membrane of the sperm.
Okay, thank you. Thank you, Deirdre, for Susie Tanaka. So, do you think any specific tests that we need before we perform oocyte activation for our patient?
Yes. We haven't a special test to detect so something is necessary or not. I think the most useful test is clear, in detail observation of the oocyte and fast water body, the appearance of fast water body, and clearance of cytoplasmic. And if we could, we can directly observe the M2 chromosome arrangement. If it's arrangement with Nomarski optics, only Nomarski optics, we can see directly the M2 chromosome arrangement. If it's normal, we don't need any other observation. But if it's not arranged well, and it's dispersed, in such case, one thing is a longer incubation, more, 5 or 6 hours. After that, we check it again. And second, I think it's also activation might be helpful.
Let's say we have a frozen oocyte. Frozen oocyte, mature frozen oocyte, or immature frozen oocytes for patient fertility preservation patients. In this case, what do you think, Deirdre? It's better we perform conventional ICSI or piezo-ICSI in such a case of frozen oocyte, mature or immature frozen oocyte?
I've had very good experience with piezo-ICSI on frozen oocytes. I think that considering what they've been through with the cryopreservation process, they do tend to be a little bit more fragile and delicate, and I definitely think the piezo-ICSI is a good offering for frozen oocytes. Absolutely.
Okay, thank you. Including the immature frozen oocyte as well.
I don't have any experience with mature. No, we haven't done anything like that.
Okay, thank you, Haroon. So please, I will repeat the questions. If we have blastocysts starting to hatch, and then we see the few trophectoderm has already been hatched, but we need to doing assisted hatching, where we can do assisted hatching in this case?
So generally, when the blastocyst is starting to hatch, it's a very rare chance that the hatching is already begun and the hatching does not complete. In most of the cases, a good viable blastocyst who starts to hatch will hatch completely. However, if the hatching is incomplete, definitely you can use laser-assisted hatching to make a small breach in the remaining part of the outer layer, the zona pellucida, so that it assists in opening up completely and the inner cell mass coming up.
So in your daily practice, do you prefer to perform partial assisted hatching or complete removal of zona pellucida? Which one you
So
prefer?
yeah, so the rationale behind complete removal of zona pellucida is that low viability blastocysts are unable to hatch even after thinning of the zona pellucida or even breaching the zona pellucida, making a small hole. So there have been some literature which says that removing completely the zona pellucida, irrespective of what method are we using, is it a chemical method or are we using laser method, irrespective of that method, has shown some promising results, especially two retrospective studies that have come out. One of them was looking at removal of zona pellucida by either thinning or breaching in fresh cycles of unselected IVF patients. So what they saw was, it was done by Lan and company, and it showed that blastocysts subjected to chemical removal of zona on day 5 implanted at a similar rate as those with laser-assisted hatching breaching at cleavage stage and on culture day 5 stage. Another study that reported that assisted hatching with total removal of zona using either laser or mechanical method significantly improved clinical pregnancy, implantation rate, and delivery rates of vitrified blastocysts compared to partial opening of the zona pellucida. So there have been a couple of studies who have encouraged removing the zona completely. However, the sample size is so small that it's very difficult to say that, okay, whether we should be doing it as a routine method or not. We definitely need more high-powered studies on this to actually offer it in cases, especially when there are low viability blastocysts or embryos available.
Okay, thank you very much. I think, I'd like to thank to all the speakers this morning. Very excellent discussions, and also to all of the participants. Today we have around 84 attendees this morning. So before we close this webinar session, I will allow you, Deirdre, what is your important message to our participants?
Well, firstly, I'd like to say thank you so much to Aspire and my esteemed co-panelists for the honour of presenting and speaking to you all today. And just to highlight that I do think that Piezoexe is a very important new technology. I think there's a lot more research to be done on it, but I think it is a very, very important new form of microinjection, and I'm really excited to see how it's going to be used in the future of IVF.
Thank you, Deirdre. The next, Sushi, Tanaka, what is your important message to our audience?
Okay, so my take-home message is the also activation is very difficult to handle because there is no golden standard when and how. So my answer is, most important thing is not only do the auto activation, but we should do first is produce a high quality egg with adequate ovarian hyper stimulation.
Okay, thank you, Susi. The last, Haroon, please, what is your important?
So my take home would be that add-ons in ART are extremely, extremely important. As we all clinical embryologists and clinicians know that. We shouldn't be wary of these add-ons, but at the same time, we should be careful with them when we start to introduce in our clinical practices. Like with laser-assisted hatching or assisted hatching in general, everyone kind of jumped into it even before there was enough data to prove that will there be any long-term effects and any short-term or mid-term effects. So yes to add-ons, definitely, because we need to get more and more people pregnant, but at the same time, we have to be very careful. We have to do it with the support of enough data.
Thank you. So once again, thank you very much to Professor Susi Tanaka, Dr. Haroon Latif, and as I said, Professor Deirdre Zander-Fox, and also to all of your audience for very actively participating in discussions. And then for Aspire as well, thank you very much for Aspire Secretariat, Jinky, and Dr. Claire Boyd as the chairman of the scientific committee. And see you on our upcoming live webinar series in the next week, Saturday, 31 October 2020.
Dear fellow Aspire members, this is Arthur Chan. I would like to invite you to join an exciting webinar, Conversation with Experts, Laboratory Factors that Impact Embryo Culture. In this Aspire webinar Mythbuster section, our invited leading experts will address important technical and managerial topics in the ART labs and have a live interactive Q&A to answer your questions. This webinar is supported with an education grant from Fujifilm Irvine Scientific. In our daily laboratory work, we often wonder what type of latest technologies and different ways of practice are evidence-based and effective on outcomes. How to implement a new generation of incubators and other equipment. What are the key factors to grow more good quality embryos through day 7, as well as maintain consistent vitrification and warming outcomes? How to evaluate our technical competency and utilize KPIs to improve success rates. How to establish a successful PGT program and troubleshoot critical steps in the PGT workflow. How to choose between efficacy and efficiency when performing laboratory procedures. And the big question, what works and what doesn't? Our 4 speakers will share their extensive knowledge and experience in various topics, discuss common myths behind many debated laboratory procedures and issues, and proven strategies to improve outcomes. Dr. Mio will discuss dry versus humidified incubator, stable temperature, pH, and osmolarity. Dr. Latif will lead the discussion on KPIs in the ART labs, select meaningful indicators, and set actionable targets. Dr. Malhotra will address the topic on day 5 through day 7 blastocyst culture and vitrification, how to make more and better blastocysts. Dr. Doshi will discuss successful PGT program development, key factors from embryo biopsy to outcome interpretation. Please join us for this exciting Mythbuster webinar. Members can register through the website or scan this QR code to connect to the registration page. I look forward to chatting with you very soon.